maintenance of the intravascular volume, as well as giving some glucose at the same time to avoid rebound hypoglycemia.
Okay.
Wouldn't that work?
I don't, the issue here is the rate of administration, the rate, how fast you are giving it, in addition to the composition of the fluid. Anytime you are giving a hypertonic fluid, you want to not, for example, this 2 to 4 mL per kilo, because of the volume, if you push that, it's of no consequence. But if you add it to your isotonic fluid and you push that into a patient, it might run into issues. Most of the issues have to do with how quickly, first of all, the veins cannot handle hypertonic solutions that much. It will sclerose the vein, that's number one. And then number two, the main issue here is that if you have a patient who is in shock, you have to push that fluid between 5 to 20 minutes. I don't think you need to worry about rebound, because once you push that fluid in, the fluid that you'll be hanging, which will be ready, should has glucose in it. So, say for example, let's say I'm dealing with a child who is 10 kilograms and comes in shock. I give 20 cc's per kilo of, I give 20 per kilo of normal saline. That's about 400 cc's. I push that in after I have originally given 2 per kilo, which will be 40 cc's of D25. As soon as I push my saline in, I'm hanging a fluid that is D5 half on, or D5 normal saline that is running at 40 cc's an hour, which will be the maintenance for that child. So it's not as if you have a gap between rapid administration of fluid and correction of hypoglycemia to when you hang fluid that contains dextrose in it. So that's why I'm thinking that in practical time, it should not constitute any problem. And except you have a child that have mesidoblastosis or hyperinsulinemia, where hypoglycemia is difficult to control. In this kind of scenario, hypoglycemia from sepsis, once you give this 20 pack D25 and you hang the fluid that has dextrose in it, I wouldn't worry about rebound hypoglycemia. There are two scenarios where you can have rebound: if you have hyperinsulinemia and you're not giving enough dextrose, or if you have a patient who is on parenteral nutrition, which we don't use in Nigeria, that has a high glucose concentration in it. And for some reason, if you stop that high glucose concentration and replace with a fluid that has low glucose concentration, you can have a rebound hypoglycemia, because the patient is already used to high glucose concentration and has a very high endogenous insulin production. But in this scenario, and in most scenarios that you will encounter with patients with hypoglycemia, I don't really anticipate that you will have a rebound. And again, in terms of sequence, I give my dextrose quickly. Why? Because I can't wait 20 minutes pushing normal saline before I administer dextrose in patient who is hypoglycemic, because they can have seizures, they can have brain damage. So I take care of that quickly, followed with my normal saline, and then follow that after the normal saline bolus, follow that with a fluid that has dextrose in it and saline. So there's some degree of continuity. And that doesn't prevent you for, if the blood pressure drops again, that doesn't prevent you from interrupting that fluid and giving another normal saline bolus. So that's kind of the way I think I would approach this if I was dealing with that case.
Thank you very much. Thanks.
Okay.
Yes, sir. Number 8. You're called to help treat an infant with severe symptomatic bradycardia, heart rate 66 per minute, associated with respiratory distress. The bradycardia persists despite establishment of an effective airway, oxygenation, and ventilation. There's no heart block present. Which is the first drug you should administer? A, atropine, B, epinephrine, C, adenosine. If you can move it up. I don't see what's on D.
Dopamine.
Dopamine.
Dopamine. Yes.
Right.
This is another question that I like very much, because in the same question they are giving you the differential diagnosis of bradycardia and the first step to take in a child with bradycardia. It says the bradycardia persists despite establishment of an effective airway, oxygenation, and ventilation. What that means is anytime you have a child that has bradycardia, because hypoxia can cause bradycardia in children, the first thing you do is make sure that the airway is patent, give oxygen. Because if you do that, if hypoxia is the cause of bradycardia, it will reverse the bradycardia. So that's the point they are making. They're also telling us that this bradycardia is not from heart block. So, however, it is symptomatic in the sense that the patient has poor cardiac output, in which case, which drug would you use? And before we go into the alternatives or the answers, I need to just mention quickly, I want to go over common causes of bradycardia in pediatrics. One is hypoxia. That's pertinent. Then 2, if you have excessive vagal stimuli. I mean, if you are in a place where you are intubating a patient, once you are putting your laryngoscope or your endotracheal tube in the airway in babies, they will be dropping their heart rate. So if you are intubating any child in your emergency department, you must give them atropine to block the vagal stimulus. That's 1. 2, bradycardia can also result from hypothermia. So we have hypothermia, hypoxia, vagal stimuli, and then raised intracranial pressure. Patient with head tumors, with shunts, patient with meningitis, and in those cases, they will have, not only will they have bradycardia, but they will also have other components of raised intracranial pressure, which is apnea or abnormal breathing and hypertension, your so-called Cushing's triad. You can also have bradycardia if there's a heart block. So if you put it down into categories, bradycardia, either you have an underlying cardiac disease like heart block, or it can be medication induced. For example, if you have beta blocker poisoning, it could be the result of hypoxia. It could be from hypothermia, and it can also be from raised intracranial pressure. If the bradycardia is reversible, if, for example, patient with hypothermia, they are cold, or patient hypoxia, and you correct the hypoxia, then you don't have to go into chest compression and stuff like that. But if it is persistent, which is what this question is telling us, you need to start CPR and give medication. In this case, what medications would you give? I will not give atropine here because there is no evidence that this bradycardia is from excessive vagal stimulus. In pediatric, once you hear the word severe symptomatic, that means the bradycardia has significant hemodynamic consequences, like low cardiac output and hypoperfusion. That child you need to start CPR, and the drug you need to administer is epinephrine. So the correct answer here will be epinephrine. because this child has symptomatic bradycardia. You want to jumpstart the heart. Adenosine is not indicated here because this is not SVT. Dopamine is not indicated for bradycardia, even though dopamine does have beta 1 and alpha agonism, but the one drug you want to use in symptomatic bradycardia or in any situation when you are doing CPR in a child, because if you want to follow the past guidelines, you should be compressing, doing a chest compression on this child. That drug of choice is epinephrine. Let's move on to the next question, if there is no comment. Hello?
Yes, sir. It's just beginning to show. Okay, so a 10-month-old infant boy is brought to the emergency department. Your initial assessment reveals a lethargic, pale infant with slow respirations and slow, weak central pulses. One team member begins ventilation with a bag mask device, 100% oxygen. A second team member attaches the monitor, defibrillator, and obtains vital signs, while the third team member attempts to establish IVIO access. The patient's heart rate is 38 per minute, with the rhythm shown here. The infant's blood pressure is 58/38 millimeter mercury, and capillary refill is 4 seconds. His central pulses remain weak, and distal pulses cannot be palpated. Chest compressions are started with IO access is obtained. Which medication do you anticipate will be given next? Adenosine, 0.1 milligram per kg rapid IVIO. Epinephrine, 0.01 milligram per kg IVIO. Atropine, 0.02 milligram per kg IVIO. Epinephrine, 0.1 milligram per kg IVIO.
Okay, I want somebody to answer this question now, because we've gone through this. What should the correct answer be? Because you can eliminate all the wrong answers and pick the right one based on everything that we've done up to this point. Any ideas? Yes, Dr. Igwe, you are correct, B. Okay, you cannot use adenosine. First of all, this is symptomatic bradycardia, and the patient is in shock. That's why they are telling you the capillary refill is 4 seconds, the pulses are weak. Anytime you hear weak pulses, you need epi to jumpstart the heart. But then they are giving you epinephrine, they are giving you the wrong dose. There's no reason to use 10 times the dose, because it's no longer, it used to be part of the guideline that if you start with 0.01 and the patient doesn't respond, you can go to 0.1. Then they found out that the high dose epi causes myocardial ischemia because of increased myocardial oxygen consumption and excessive tachycardia. So the best thing to do is good quality chest compression, 15:2, and also give epi. You can repeat the epi every 3 to 5 minutes during the code, and the correct dose here will be 0.01 milligram per kilogram. Atropine, in adult ACLS, they use atropine for bradycardia, but in pediatrics, we use epinephrine. And the correct dose here is 0.01 milligrams per kilo. Before we go to the next question, the one thing that I want to emphasize here is that you should start to think about organizing your resuscitation team. When you respond to code, you should have a team approach. Somebody should be in charge of chest compression. And that's what this question is emphasizing here. The first team member, the second team member, and the person who is doing chest compression, because it is recommended that you have to do that chest compression at least 100 to 120 compressions per minute. People get tired easily. So whoever is doing the chest compression, every 2 minutes, you have to rotate them. Somebody has to be in charge of the airway, doing bag and mask. Somebody has to be in charge of IV line. And then the person who is the head of the team is the one person who will be ordering every team member, who is assigning them to a particular task. That is what I like about this question here. It's not just the answers, it's telling you the organizational approach to running a proper code in pediatric. There has to be a team leader, and there have to be team members who are knowledgeable about the current PALS guidelines. And the team leader has to assign each member of the team to a particular task during the code. Okay, so we can move on now to the next question. Let me show that. Okay. Yes, can we read this?
So you find a 10-year-old boy to be unresponsive. You shout for help. And after finding that he's not breathing and has no pulse, you and a colleague begin CPR. Another colleague activates the emergency response system, brings the emergency equipment, and places the child on a cardiac monitor / defibrillator, which reveals the rhythm shown here. You attempt defibrillation at 2 joules per kg and give 2 minutes of CPR. The rhythm persists at the second rhythm check, at which point you attempt defibrillation with a 4 joules per kg. A fourth colleague arrives, starts an IV and administers 1 dose of epinephrine, 0.01 milligram per kg. If ventricular fibrillation or pulseless ventricular tach persists after 2 minutes of CPR, you will administer another shot. Which drug and dose should be administered next?
Okay.
So epinephrine, 0.1 milligram per kg IV, adenosine, 0.1 milligram per kg IV, lidocaine, 1 milligram per kg IV, and atropine, 0.02 milligram per kg IV.
Okay. First of all, because the last statement there might cause confusion. You can see that this is a wide complex tachycardia, so this is VTAC. Because the last statement says, if ventricular fibrillation or pulseless VTAC, this is not fibrillation. They just wanted you to know that the way you treat pulseless VTAC, which is this case, is the same as the way you would treat ventricular fibrillation. And if you can look at the evolution of this case, they first of all started at 2 joules per kilo. And they started CPR, 2 minutes. And once they tell you they are doing CPR, that means somebody is doing chest compression, 15 compressions to 2 ventilations at 110 to 120 compressions per minute. And every 15 minutes, every 3 to 5 minutes, they give epi. But then the reading did not change, so they need to shock the second time. So they went up to 4 joules, like I was trying to show you during this scenario. You start at 2, you go to 4, and then you repeat another dose of epi. So they are now saying, if you have given epi and you have shocked the patients with increasing dose of energy, which other drug can you use? Definitely it's not epinephrine again at this point, but then the dose of epinephrine given in this answer is not the appropriate dose. It is not adenosine because this is not SVT, and this is VTAC without a pulse. Okay, you only give adenosine for SVT. Lidocaine is the drug of choice. If you look at your PALS, there are 3 drugs that you can use for VFib or VTAC apart from epinephrine: lidocaine, amiodarone, or procainamide. So in this case, the only drug that is listed that is consistent with the current guideline is the lidocaine. So the correct answer here should be lidocaine. Okay? And of course, this question also tells you the sequence of events when you are shocking a patient who is in VFib or pulseless VTAC. Use increasing energy level up to a maximum of 10 per kilo. You use epinephrine, you can use lidocaine, procainamide, or amiodarone. Okay? If you choose to use amiodarone, don't give procainamide. You have to choose one. But you can do lidocaine, and then if it doesn't respond, you can follow with amiodarone. Okay? So let's go to the next question. We're almost done. Okay. Question.
A 1-year-old brought to the emergency department for the evaluation of poor feeding, irritability, and sweating. The child is lethargic but arousable. He has labored breathing, very rapid pulses, and a dusky color. His respiratory rate is 68 per minute, heart rate 300 per minute, and blood pressure 70/45 millimeter mercury. He has weak brachial pulses and absent radial pulses. A capillary refill of 6 seconds, SpO2 85% on room air, and good bilateral breath sounds. You administer high flow oxygen and place the child on a cardiac monitor and see the rhythm shown here. The child has no history of congenital heart disease. IV access has been established. Which therapy is most appropriate for the child? A, consult with pediatric cardiology. B, perform immediate defibrillation. C, administer isotonic crystalloid fluid bolus of, mils per kg. So I can last.
Okay. Hello?
Yes, sir.
Okay, administer adenosine, is that's the last option, right?
Okay, it's not visible here. So administer adenosine. That's D.
Yes, rapid push. Okay.
Okay.
So, first of all, this child is dying, so I can't be calling, if I'm the resident in the ER, I have to do something before I consult cardiology. So the cardiology will come, but you are the front line, you have to do something right there. So that is not an option. Perform immediate defibrillation. This is not correct because first of all, what reading is this? This is SVT for sure. And this is SVT, symptomatic SVT, because the patient is in shock. He has weak pulses, the blood pressure is weak. So if you have to shock this patient, it will not be defibrillation, it will be cardioversion. So they're trying to make sure you know the difference. Defibrillation is what you do for VFib and pulseless VTAC. And you have to use a high energy level, and you do not have to synchronize. Cardioversion is what you do for this kind of cases, SVT, and the energy level is lower, and you have to synchronize. So by saying defibrillation here, that is not the option. Giving fluid in this case is not indicated. What needs to be done in this case is adenosine. Adenosine, while you are ready to do synchronized cardioversion, because once they are in shock, the common saying in critical care is, once they are in shock, shock them. If the shock is due to SVT, then you do synchronized cardioversion, energy level 0.5 to 1 joules per kilo. In practice, at times we go up to 2, but you start at 0.5 to 1. That is, if you are doing an MCQ in an exam, it's 0.5 to 1 joules per kilo. And for adenosine has very rapid very short half-life. If you are slow pushing it, it would disappear before it gets to the heart. So that's why they are always telling us to push it, rapid push. You are pushing the drug in and you are following with saline rapidly. Once you do that, by the time you're doing that, then you should be ready to cardiovert the patient. So the correct answer here is D, but that's drug treatment. But the ultimate treatment here for symptomatic SVT is synchronized cardioversion. So we go to the next question quickly. If there are no questions or comments. Okay. How about this one?
Okay, so an 8-month-old infant is brought to the emergency department for evaluation of severe diarrhea and dehydration. On arrival to the emergency department, the infant becomes unresponsive, apneic, and pulseless. You shout for help and start CPR. Another provider arrives, at which point you switch to 2 rescuer CPR. The rhythm shown here is seen on the cardiac monitor. The infant is intubated and ventilated with 100% oxygen. An IO line is established and a dose of epinephrine is given. While continuing high quality CPR, what do you do next? A, give normal saline, 20 mL per kg IO rapidly. B, give amiodarone, 5 mg per kg IO. C, give atropine, 0.02 mg per kg IO. D, give epinephrine, 0.1 mg per kg IO.
Okay, so if we look at these questions, we can eliminate B and C quickly. Number one, this child is not in VFib or VTAC, so he doesn't need amiodarone. He doesn't need atropine because this is not vagal bradycardia. This child is in shock. And 2 things here. Remember, they said you shout for help and you start CPR, so which means initially you are the only one doing CPR. When you are the only one doing CPR, the ratio of compression to ventilation is different from when there are 2 of you. When you are the only one doing it, it is 30 compressions to 2. And you know why they made that recommendation? Anytime a child needs CPR or any patient needs CPR, your emphasis is on pumping the heart. That's the only way the child is getting or the patient is getting cardiac output. So if you are by yourself, you need to spend more time compressing the heart. That's why it is for a single bystander CPR, because we did not mention that, but it's implied in this question. It is 30 compressions to 2 cycles of ventilation. So pam, 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 fast, 100 to 120 per minute. You count up to 30, you stop, then you bag the patient twice with bag and mask, then you go back to chest compression. Then when your another doctor came by, then you guys switch to 2 rescuer. When you get to 2 rescuer, the ventilation to compression ratio changes. Then you go to 15 to 2, which is all we have been saying all day. Okay, now going to the rest of the question. We are told at the beginning that this patient has severe diarrhea and dehydration. You've been doing CPR and you've given epinephrine. So the next thing to do is to restore intravascular volume, because you know this patient is dry. So the answer here is normal saline. They put epinephrine there because if you think of epinephrine, which can be given in this scenario, the dose is wrong. It's not 10 times the standard dose. This is 10 times the standard dose. So epi is wrong, atropine is wrong, amiodarone is wrong. The correct answer here is 20 cc per kilo of normal saline. Any questions? So we go to the next.
Sir, Excuse me. Thank you very much. Please, could you please comment on the ECG apart from the bradycardia? That's of about 40 something.
Yes.
Rates per minute. What other comments do you have on the ECG, please?
Yes, it looks like the first of all, it's bradycardic, and then secondly, if you look at your QRS complex, it looks like what it would be idioventricular reading. Why is that so? Anytime you have a heart rate less than 60, that means the pacemaker function of the heart is not coming from the sinus node. Because every cell in the heart has inherent automaticity, the highest automaticity being that of the sinus node. So in a patient that for some reason the sinus node is not doing anything, either because of severe hypovolemia and shock, the myocardium, not the AV node now, might take over the pacemaker function. And when they do, you see a very slow heart rate with a QRS complex that is wide, because the conduction is not going through the efficient conduction fibers, your His bundle and your Purkinje fibers. So if the conduction is going through the normal pathway, it's very fast. And you can see, so this slowed, I would call it an idioventricular reading, because during CPR, remember they said the infant becomes unresponsive, apneic, and pulseless. So initially, this kid had no pulse. And then once they started CPR and they started to give epi, they are stimulating the heart, and it looks like the myocardium is taking over the pacemaker function at this point. That's why you have this kind of reading. So I would say it looks like idioventricular.
Thank you, sir. Please, can we expect this kind of picture from severe hypokalemia?
Anything that will stop the heart from functioning, and then when you are trying to restart the heart, whichever part of the heart is assuming the pacemaker function, if it is the AV node or the myocardium, you can see this. For example, in severe hypokalemia or hyperkalemia, before they go into cardiac arrest, you can see what looks like this. May not be exactly, because then the Q, you have the so-called, I've forgotten that is the U wave, where this QRS complex start to flatten out. And you see, so you can see this in severe, anything that would affect conduction in the heart and slow down automaticity of the SA node, because the SA node is highly sensitive to hypoxia, and it does require a normal cardiac output. So in a patient like this with hypovolemia and shock, there's nothing going to the SA node will just stop. And once you start restarting the heart, until you restore normal intravascular volume and normal cardiac output, the pacemaker function might be taken over by other tissues, like the myocardium, for example. And that will give you this kind of bizarre looking EKG tracing. That is why what makes sense here is not giving more epi, is to try to restore intravascular volume. So if you give 20 cc's per kilo times 2, and the patient's blood pressure is still low, then you can repeat your epinephrine, but the dose will not be 0.1, it will be 0.01 milligrams per kilo. Okay?
Thank you, sir. Thank you very much.
Okay. So we go to the next question here. Okay.
You're caring for a 3-year-old with vomiting and diarrhea. You have established IV access. The child's pulses are palpable but faint, and the child is now lethal. The heart rate is variable, range 44 per minute to 62 per minute. You begin bag mask ventilation with 100% oxygen. When the heart rate does not improve, you begin chest compressions. The rhythm shown here is seen on the cardiac monitor. Which would be the most appropriate therapy to consider next? Transcutaneous spacing, atropine, 0.02 milligram per kg IV, synchronized cardioversion at 0.5 kg, epinephrine, 0.1 milligram per kg IV.
Okay, so if you look at it, this patient is in complete heart block. Okay, you can see the T waves and not having any no direct relationship with the QRS complexes, and occasionally there's an escape. Just one of the readings here, I think 1, 2, 3, you can see the P waves immediately after the QRS, but this is heart block. And if you go by the PALS guidelines, the treatment of choice is atropine. This cannot be synchronized cardioversion because this is not SVT. Epinephrine, the dose here is 0.1 mg per kg. It's not recommended for heart block scenario. Transcutaneous spacing would be the next alternative, but first of all, even where you have the ability to do if you have the ability to do transcutaneous spacing, to set it up is a different problem. So what is available to you, and if you look at your PALS card, is to do the atropine 0.02 milligrams per kilo. So that is the correct thing here. So A, you have to recognize this as heart block, and B, you have to know that on your PALS algorithm, you can do atropine while you're preparing to do transcutaneous spacing. And if this heart is seriously sick, then ultimately using an implanted pacemaker might be the next thing to do. Okay, so the next question, we're almost done now. Okay, can you go ahead and read this for us? Hello?
Sorry about it, I was mute. A 4-year-old boy is in pulseless arrest in the pediatric intensive care unit. High quality CPR is in progress. You quickly review his chart and find that his baseline corrected QT interval on a 12-lead ECG is prolonged. The monitor shows recurrent episodes of the rhythm shown here. The patient has received 1 dose of epinephrine, 0.01 milligram per kg, but the rhythm shown here continues. If this rhythm persists at the next rhythm check, which medication will be most appropriate to administer at that time? Lidocaine, 1 milligram per kg IV, adenosine, 0.1 milligram per kg IV, epinephrine, 0.1 milligram per kg IV, magnesium 25 to 50 milligram per kg IV.
Okay, this, first of all, we didn't talk about this reading, but it's relevant. They give you a hint. Anytime we hear prolonged QT, which can be seen in pediatric, there are some patients that has congenital prolonged QT. So let's not even think about those ones, because they will just be dying at home, except you have the capacity to make the diagnosis by genetic studies. But the ones that should bother you in your practice environment are those patients who are on medications that can cause prolonged QT, like chloroquine, like erythromycin, any drug that can cause that. If the patient is on that kind of medication and shows this reading, this is called Torsad, the point. It's just VTAC that has different shapes. you can see that if you look at the left of your screen, it looks like a normal VTAC, and then there's a wavy line which is different from the first one, and then there's another, the amplitude changes. That's why they call it torsades. And the treatment of choice for torsades will be magnesium sulfate. So take a look at this. If your EKG tracing ever looks like VTAC with different shapes in a patient that has prolonged QT, even if you don't know the patient has prolonged QT, if it's on medication that can cause prolonged QT, like all these antacids, some antibiotics, and our very common chloroquine, then you need to know that this is torsade and the treatment of choice is magnesium sulfate. Okay, so the last question that I will talk about is this.
Okay, so a 3-year-old unresponsive apneic child is brought to the emergency department. EMS personnel report that the child became unresponsive as they arrived at the hospital. The child is receiving CPR with bag mask ventilation. The rhythm shown here is on the cardiac monitor. A biphasic manual defibrillator is present. You quickly use the length from head to heel of the child on a color-coded length-based resuscitation tape to estimate the approximate weight as 15 kg. Which therapy is most appropriate for this child at this time? Attempt defibrillation at 10 joules and then resume CPR, beginning with compressions. Attempt defibrillation at 30 joules and then resume CPR, beginning with compressions. See defibrillation at 30 joules and then open the airway and check for a pulse.
Okay. First of all, we all agree what rhythm is this? Yeah, I know it kind of looks like this is not torsade. This is ventricular fibrillation, but it's the coarse VFib. You remember during the scenario, I showed you fine VFib and coarse VFib. At times, the coarse VFib can be confusing because it looks like VTAC, but you can always tell if you see this on the monitor and the patient has no pulse, you just shock the patient, because even if it's VTAC, the treatment is the same, because a pulseless VTAC and VFib treatment is the same. But this what we are looking at here is a coarse VFib. And that's why they're telling you, they're just trying to test your understanding of the fact that you have to start defibrillation with a very high energy level. The kid is 15 kilos. So 2 times 15 is 30. So you cannot do 10 joules. It has to be 30 joules. Attempt defibrillation at 30 joules, resume CPR, beginning with compressions. Then C, attempt defibrillation at 30 joules, and then open the airway and check for pulse. So the question would be, why is C wrong? C is wrong because the emphasis in pediatric resuscitation is chest compression to resume cardiac output, because that's the only way you are manually pumping the heart. That's the only way this patient is going to get cardiac output. Any time you spend not doing CPR is time wasted. So you cannot be, for example, shock this patient and then be looking for ways to intubate him, getting the laryngoscope ready, doing IV. All those things are important, but what they're trying to tell you is, once you shock the patient, start CPR right away. And then once you are continuing CPR, you can be planning and getting ready to do other things. So the correct answer here is B. So that brings us to conclusion of this course. I'm only going to spend the next 5 minutes before we disperse. We have gone longer than what we planned, and I kind of apologize for that. It's unpredictable because of the constant break in transmission. We have to spend more time, but I'm going to wait to hear from you if you have any questions, but then I have some very important comments to make, and then we come to a close. So the floor is open for anyone who has comments or questions in general. It's our HOD back online now?
Yes, I've been here.
Okay.
Yes.
All right.
Thank you, sir.
Okay.
You can see that we had 45 or so at the beginning, but we still have 30 people. That means it's time well spent. Even if we spent another 1 hour, I know many people that will remain. People like me will still remain. If not, I'm still in the office and I'm keeping the office people in the, otherwise I would have just stayed on and on and on. It's been a wonderful time. And of course, we're not going to remain the same. I also did PALS many years ago. I did APLS as well. But PALS is just simple enough for everybody to follow. And one of the things that you have brought out is this idea of having a team. You can't be resuscitation and have confusion. There has to be a team lead, and then everybody will be assigned roles, and you take it from there. That's one of the things that even if we don't change any other thing, we must change that. We can't have a disorganized resuscitation from today onwards. And then we're trying to look for monitors, and we're going to get, we have one right now, as I told you, and then we're going to get a few more, so that when we put on the, when we see the rhythms as you have shown us, we have, at least let's recognize what the rhythm is and what needs to be done next. You can see that epinephrine is very handy with most of the issues we've dealt with today. I was also going to ask you that amiodarone seems to be a universal drug. Is there one condition that you must not use it in? I know I remember that. That is one drug, if you ask anything, it's almost come true with a lot of the abnormal rhythms, but I don't know how available it is here. It's the cardiologist who will be asking. But at least we've taken a lot away from the training today. Thank you very much. So in case nobody else says any other thing, these are some of the things that I've taken away.
Well, I kind of thank you, and I want to say thank you for making it possible for us to organize this. And I also want to thank everybody who is present. This is it's a lot of motivation to stand here for 2 hours, and so I want to, give everybody a compliment for doing that. Remember that those of us who trained in Ibadan, we have a loyalty to that institution. I particularly, I remember those who trained us. I mentioned their name at the beginning of this course. They were dedicated and extremely talented teachers. I mentioned their name at the beginning. I remember Dr. Folami in nephrology, Dr. Famakinwa in endocrinology. I can name their names. And I can tell you that back then, one of the patients that I had as a house officer was a patient with pyromyositis and septic shock. I can never forget that patient. That patient was treated with digoxin and left the hospital without any equipment, but because the people were excellent clinicians, they were able to recognize this, and that patient survived. However, things have changed. I do not anticipate that we will have all the technology that we have over here. But I agree with you, at least in the emergency department, if we can have monitors, we don't have to have, the ideal setup with that, you should have monitors in each room in the emergency room. You should have monitors in the nursing stations in the wards, and you have monitors in the ICU. However, if we are not at that stage, we should still have some monitors in the emergency room, and we can identify those patients who are very sick. Even if we have 2 or 3, those ones are the ones to be monitored. As you can see from today's exercise, if we do not monitor these patients, we do not know what is going on, and the treatment cannot be as effective. So you actually took words out of my mouth. I was saying here, I was taking notes that the concept of team and emergency response, maybe every month we have to have a resident and nurses who will be a code team in the emergency room or a code team in the pediatric who will respond to any code situation. And we can start from there. The other thing I also want to mention is vascular access. I'm sure we do intraosseous at home, right? Because the last time we were there to teach this course, we talked about intraosseous access, because there will be situations where you cannot get an IV in these patients and you have to give them medications intraosseous, which is what they were referring to here. These questions that I'm showing you were all from the American Heart Association, and that is the way we do it here. You first of all do basic questions to test your understanding of the physiology and pharmacology of CPR. And even though I have been practicing critical care for over 24 years now, every 2 years, the hospital expects me and every physician to renew their PALS card. That tells you that nobody's exempt. So I'm happy to see the turnout and the motivation here. So one of the things we can do is you have the video and you have the card. Maybe every month, the residents, particularly those ones in the ER, should be made to review the video and the pulse, and whatever level of monitoring that you have that you can do will be helpful. I congratulate you all for the level of motivation, and I'm willing to help as much as possible. The one thing that I wrote down again is the Broslow tape. You can see, do we have that tape? In case you have a child, you don't know the weight. That was what they were referring to in one of the questions. You just put that tape from head to heel, and whatever weight is revealed is the estimated weight of the patient. The Broslow tape, if you don't have it, by grace of God, if I have anybody coming to Nigeria or when I'm coming, I will bring a Broslow tape that can be available in the ER for you. And I think the last time I was there also, I left some pulse oximetry with Dr. Akindolue. So we can use that at least to do spot checks on patients with pneumonia and see what their oxygen saturation is like. You only need
Hello, sir. He's muted. He muted himself. Hello, sir. You've muted yourself. Oops. Oh, no.